Hi, I'm Pamela Addy, and we are going to continue week 9 with chapter 4, develop exam protocols and evaluate results. Being in imaging over 45 years, I can tell you that protocols have evolved in their utilization and purpose. They ensure safety and they increase productivity. They also enable the technologists to be more involved in checking for inappropriate orders and in a variety of clinical scenarios. Protocols should be developed in collaboration with your radiologist for high quality imaging and lowest possible radiation. In today's world, often the EHR can be used to allow the radiologist to select the appropriate protocol and sending that information back to the technologist via some type of electronic work list. So, as I'm sure you're aware, all protocols are modality specific and each has their own set of considerations. We're going to go through these slides, take us through each modality and just touch on the considerations for each. And I'm sure there is not going to be a whole lot of this that you're not already familiar with. General X-ray protocols should list parameters for exposure technique, equipment settings, and proper shielding. Now, shielding is something that has kind of evolved into a more consistent protocol approach today. So back in the day, we kind of just used shielding when we wanted to. You know, we knew we were supposed to, and if we thought it was appropriate, we did, but I couldn't tell you that every single person used it consistently or in the same way. So now with written protocols about when and how to shield, we can know that we are providing a consistent service for especially our children and pregnant women patients. So with CT, we know that the dosage is a critical parameter and it must be standardized, and our technologists have very little opportunity to deviate from that on their own without radiologist approval. And in addition, it must be determined if contrast is needed and if the patient has any contraindications to contrast. So many times that means age or medical status in terms of their labs and their creatinine clearance. So the protocols for fluoro is another modality where dosage must be developed, the guidelines must exist, and it must be monitored. IR presents many complexities in developing protocols due to the variety and the acuity of the procedures. Sometimes, or most times, I guess, an H&P is now needed, as well as the timeout or the pre-procedure pause, whatever you're calling it, which must be specific and it must be documented. So anyone that does mammography knows that it needs to require, that it requires specific screening regarding age, lumps, pain, implants. I'm sure there's probably a few more things as well, but all of the protocols for mammography again have to be very specific, very clear. A technologist can't do one thing for a patient one time and then next year when that same patient comes back, a different technologist performs it in a different way. It must be consistent. Now, we certainly know that the screening and the safety protocols for MR are extensive due to the consequences, the significant consequences that can occur. And for MRI, I think you should go outside the box a little bit and discuss when nursing from other departments or transport may be coming into an MRI center, an MRI room, and also when you have a safety issue that requires your local EMTs or fire department to come into the MR department and or room. I've seen many times where outside personnel came in, emergency personnel, and said, turn off the magnet, which we all know is not possible. So nuclear medicine protocols differ from the other modalities due to the nature and handling of the radioactive materials and the strict regulations that are in place. And for for nuclear cardiology, you need to remember you're dealing with cardiac compromised patients and have emergency protocols in place. I had an outpatient for nuke med stress test that expired during the procedure with the cardiologist present. I will never forget it, and certainly it means every job I had after that, I always made sure we had emergency procedures and protocols in place. Again, general nukes, a lot of regulations requiring the handling of radioactive materials. Also, protocol must be in place for a misadministration. And I have seen that happen more times than I want to tell you. And there has to be very specific guidelines to identifying the misadministration, informing the referring physician, finding out if there are any contraindications for that patient, and reporting it to, oftentimes reporting it to the state. And again, nuclear cardiology must have protocols in place to address issues for adverse events. And that might be from a simple heart rate event to something we talked about more emergently. PET-CT is another area where the technologists may be operating on their own, so standardized protocols are really, really helpful. So many times we don't think about safety issues in ultrasound, but we still need to have emergency protocols in place if we identify a testicular torsion or an ectopic pregnancy. Ultrasound is also an area that really supports standardized protocols and structured reporting. Also remember, it's so highly tech dependent, which is another reason for standardized protocols. Vascular access is another area where we may have a protocol that guides the technologist if they're unable to successfully achieve access within a certain number of sticks, or a protocol to change the injection rate if they can't get an AC access for a CT, for example. So again, patient safety is the primary reason for having all of these protocols in place. And they need to be flexible enough to account for differences in patients. We are operating now with contrast agents in CT, in MRI, in echo, even in ultrasound in today's world. And adverse side effects from administration of any of these drugs or radiopharmaceuticals could develop it from a minor physiological disturbance to severe life-threatening situations. And we need to understand what the high-risk examinations are and help our technologists know in advance what to do when these things happen. You know, patient handoffs are a major major safety risk. And we don't always give enough attention to patient handoffs. But because they're a critical risk area, what better way than to develop protocols that standardize the process of the handoff? And what's our favorite word? Communication. So again, communication failures are considered to be a contributing factor to adverse events in inpatients. And remember, developing the protocols is just half of the process. Training the staff and assessing competency must be documented. And at this point, I think, or at least I hope, that everyone has a process in place for reporting and analyzing critical results. We can always learn from analyzing the results and the actions that happened in these cases. I love to say that diagnostic imaging is the intersection of science and art as we respond to all of the clinical situations that we see every day and still produce the highest image quality so our radiologists can provide an accurate interpretation. Thank you.